My name is Norma Almanza. I'm with the Texas Department of Insurance, which is a state agency. Every state right now has an insurance department. And my job within the Department of Insurance is to assist Medicare beneficiaries and their caregivers. So for today's presentation, when I was asked to speak on the Affordable Care Act, you have a two-page handout that you should have picked up at the table. It's called Seniors and the Affordable Care Act. And I'm going to limit myself to those provisions of the law that I know are impacting Medicare beneficiaries. And if you go to that website from where that is downloaded from, you can actually find some of the key information that I'm going to give you. So I'm first going to talk about what are the changes to you as beneficiaries today in 2013. And as your handout says, one of the first things we saw after this law passed was a rebate to the Medicare prescription drug plans. If you had a Medicare prescription drug plan, you got directly from CMS a $250 check. How many of you remember that? Okay, some of you do. Okay, if you had a Medicare drug plan, how many of you have Medicare and your second insurance is a retirement plan from somewhere where you worked? Okay, then you did not have Medicare standalone or Medicare Advantage prescription drugs. It was only if you had the Medicare prescription drug plans. Okay, and that is changing now. How many of you are state of Texas retirees? Okay, some of you. You're beginning to see changes in how you're getting your benefits for the first time in the last 2 years. So the insurance company changes really do impact. The other thing, again, if you have Medicare standalone prescription drugs, or if you have your drug benefit through a Medicare Advantage plan that is not your retirement plan through Aetna. How many of you are teacher retirees from the teacher retirement system? Okay, that's, even though it's a Medicare Advantage plan, it's different. So for those other individuals, when you go into what is called the donut hole, the donut hole was that period when you had no help from Medicare in paying your prescriptions. The concept is to begin to close that hole. So when someone has initially, and by the way, some of you look very, very young to be here, to be on Medicare. Out on the tables will be this book. This is called Medicare and You, 2013. How many of you who are already on Medicare know that you get this book at home in the mail? Every year you get this when you're on Medicare. And the very first inside cover tells you what's changing in Medicare in 2013. So, sorry, did I lie? Page, not the first inside cover, they changed it on me. On page 4, it says, if you reach the coverage gap donut hole in your Medicare prescription drug coverage, you will only pay 47.5% for your brand name drugs, or you will only pay 79% for your generic drugs, and once you're out of that donut hole. So by 2020, everyone with Medicare prescription drug coverage, and I guarantee some of us that are retired from the state will eventually be retired, that will probably be over there, you're going to be responsible for only 25% of the cost of your prescriptions. Why? We're living longer because of that prescription coverage. Okay? So the other change that happened in 2013 is getting certain Medicare beneficiaries who have higher incomes to pay more for their Part B and Part D premiums. Part D is that Medicare drug coverage. So if an individual is on Medicare with an income of over $85,000, just one person, and for a couple it is $170,000 income. And by the way, income is defined even what Social Security gives you. But if you have any pensions, those individuals will pay more in their premiums. The rest of you will continue with the premiums as, set by Medicare each year. You're not going to pay that higher cost. Okay? That's one way of keeping more money in the trust fund. The Medicare, the Affordable Care Act is a very, very large piece of legislation, and it's meant to be implemented over 10 years. Part of what you heard from Dr. Salman is what Medicare is changing for physicians and hospitals, and I will talk about that. Another thing that Medicare, the Affordable Care Act did is it passed in 2010, and immediately for certain preventive tests and exams, you don't have to meet the Medicare deductible, you don't have co-payments. And Medicare has tried working with physicians to say, hey physicians, and on page 51 of that book, if you're writing, on page 51 of the Medicare and You book, there is literally a table, 2 columns, that says, as a Medicare beneficiary, we encourage you, based on medical scientific data, to get these preventive exams. So many more of those are at no cost to you, so that you're on a fixed income and you don't go get that test. And they dictate when you do get that test based on medical information. So that's another change that happened as a result of the Affordable Care Act. What you're going to see in this patient-centered medical model is you're going to see physicians working with their staff to say, hey, are these individuals getting those preventive exams? And oftentimes, some of you, how many of you here are seeing possibly 2 and 3 doctors right at this clinic? Okay. So the patient-centered concept is which doctor's going to take ownership? Not necessarily as a gatekeeper, but who's going to be the one that's going to be making certain, are they getting all these preventive exams? Is someone coordinating that they're not taking a prescription that they received for something for treatment 5 months ago and no longer need? So that is part of that concept. Another thing that directly impacts, and it won't impact you, it impacts those younger folks. You paid for Medicare to be available to you when you pay your FICA taxes while you're working. So there is part of a provision in the Affordable Care Act that is going to require people, while they're working and paying into FICA, to pay more. And it's like a 1-point-something%. That's going to be another way of keeping the Medicare trust fund secure. Now let me talk to you, so those are the things that are happening in 2013 and have already happened. Let me talk to you quickly about other changes that are going to impact you. And those changes come in the way of trying to reduce Medicare spending. Part of the reason we have models like this is Congress, when we say Medicare, it's really Congress, because Congress is the one that dictates the rules. Congress has said, how can we cut? And therefore, you've probably read in the paper that there are cuts to physicians, there are going to be cuts to hospitals, and those cuts are, and there are also models that are out there. In your Medicare and You book, you'll read about what are called accountable care organizations. There are Medicare-dictated accountable care organizations, but in reality, some health providers are already coming to you. A hospital that has rooms wants those rooms filled every day if possible. That's how they meet their cost. That increases what Medicare pays. That patient who gets sent home too soon or gets released on a Friday, but they need home health care, or they get released and they needed to go to a skilled facility and that wasn't coordinated, that's going to cost more. That patient is going to wind up back in the hospital. So part of the law is working with providers and saying, either you look within yourself to how to improve the care of your patient so that it costs less. Hospitals, if we keep seeing the same patient being readmitted, we're questioning the quality of your care. We are going to cut your reimbursements. Again, that's my lay version of it, and a very quick version. So you're going to see some of that to hospitals. You're going to see the same to skilled nursing facilities. Many of the cuts that are part of the Affordable Care Act are, and by the way, some of those cuts that are coming to individual doctors were things Congress did way before the Affordable Care Act. And you know, you read about, well, how do we stop these cuts to doctors? Again, if the Affordable Care gets implemented, some things are already in place and had nothing to do with the Affordable Care Act. But the Affordable Care Act does include cuts to Medicare Advantage plans. I explain Medicare Advantage plans this way. Those plans, and they are insurance companies, Humana that you mentioned offers managed care plans, offers Medicare Supplement policies. They're an insurance. Humana is an insurance company. When Medicare Advantage plans began, those insurance companies told Medicare, we can do it better than traditional fee-for-service Medicare. You know, we can take them on as members, we can provide all of their care, we're going to give them a gatekeeper, not as a negative thing, but that gatekeeper is going to make certain that this patient is getting the right thing. For that, Medicare, Congress agreed to pay those plans more. They get paid something every month for every member, whether that member sees a doctor or not. They were supposed to bring costs down. Those costs have not come down. And therefore, part of the Affordable Care Act is saying, we will bring costs down. You're going to see less Medicare Advantage plans. That is a result. So your you know, current Medicare Advantage plan may go away. Some of them have already gone away. It used to be most Medicare Advantage plans were HMOs, which have the gatekeeper. More of the plans now are PPOs that don't have a gatekeeper. So those are changes you're going to see to Medicare Advantage. The other part of the Affordable Care Act was improvement in the delivery and the quality of care that Medicare beneficiaries are getting. What you're seeing here is a concept of improving the care. If you're seeing 4 specialists, who's coordinating that the medication one prescribes isn't counter to the other medication you're already taking? By the way, in 2013, back to Part D, for the first time now you're also going to get a call, not only possibly from your clinic here, you may get a call from your pharmacist. And they're going to say, we need you to come in because you take all of these prescriptions. When Medicare pays the claims, they know that there are some people who are taking various drugs, some of which have adverse impact, one to the other. So Medicare, again, trying pilots, has said, okay, the best place to grab hold of this issue is at the pharmacy. So on page 92 of this year's Medicare and You book, you're going to read about medication therapy management. And my mother already got a call. And they didn't explain it right. And she said, I'm not going to talk to you about this or that. That's my doctor's decision. Sometimes they don't explain it very well, and that's what hurts us. I'm looking for my water. Excuse me. So that's another change. But on the quality of care, you're actually seeing some accountable care organizations in the area. You're going to see efforts like this, but I can guarantee you, even in this model, it's your insurance that's going to dictate whether you're in a PPO or you're not in a PPO. If you are in original Medicare and you have a supplement or your employer works with original Medicare, how do you know if you have original Medicare? How many of you know what you have? Okay. How do you know?
I have Humana Medicare Advantage.
That's not original Medicare. That's a Medicare Advantage plan. If every quarter you get a Medicare summary notice that begins with, "This is not a bill," you are in original Medicare if you get that statement every 3 months. If you're in original Medicare, you have the freedom to go to any doctor anywhere. But because of efforts like this, you're going to see some doctors who will say, I don't work with any Medicare Advantage plans. Tomorrow that may change. I know that when I was planning for this, I asked, do you accept the United Healthcare ERS Medicare plan? That is, it's not a true Medicare Advantage plan because it's employment sponsored, but it does work like a managed care plan. Originally, many doctors in Austin said, no, we won't accept it. Some of them actually did not and have not. Others have changed. I understand here they will accept it for those ERS clients that they've already had. They will accept the Aetna Medicare Advantage plan that comes from teacher retirement. So we've got some issues out there. The quality, though, is supposed to improve for you without being, and that was the first thing in that handout that you saw, is it says you're still going to have choices. Well, what I tell people is, in reality, your choices do become limited because it's based on what insurance you have or not. So you're going to see more efforts by hospitals working together with physician groups. You have some ownership. Like I said, you play a role in it, taking those preventive exams, asking those questions about why do I need to see this one and this one and this one. So those are the things that are in the Affordable Care Act as right now. The things that have not talked about and that you're seeing in the news a lot is what's changing for those who are age 50 to 64. How many of you in that boat? You're not on Medicare. Okay. In October 2013 for January 1, 2014, you're supposed to be able to, as non-Medicare, be able to buy insurance on your own. Most individuals may now, and we know, and the articles are there, they're saying some of you may have insurance, it's very expensive. You're going to be able to purchase affordable. Now, and that's a question, I shouldn't say that, I take that back. You'll be able to purchase insurance even if you've had a stroke, even if you're a lifelong diabetic. But those changes are to other age groups. You've heard about Medicaid. Medicaid is not Medicare. Medicaid is that program that is run by the state with federal money that helps people who have very limited incomes. They're usually disabled, not yet eligible for Medicare, maybe on a waiting there. They're usually children with developmental disabilities. So in a very short nutshell, that is what the Affordable Care Act. The Affordable Care Act does not change if you have Medicare. So you would not drop your Medicare and go to one of these exchanges in 2014. Not meant to work that way. Medicare will still be there, and the hope is that all of these congressional efforts, now right now, what you heard about was sequestration. Congress would like to see cuts to Medicare sooner than in 10 years. So that, you know, they would like to, they say, hey, we need to keep people from going to the doctor because you guys have nothing better to do. You just love to doctor shop, right? Not so. So there is an effort to push something through Congress. I can tell you, even when Congress passes something, it takes them an average of 4 to 5 years to implement it. So right now, the Supreme Court has upheld the Affordable Care Act. The changes that you're going to see in Medicare will be in your books, and you will see some, you may have issues as providers, clinics say, I will or I won't participate in some of these efforts. It behooves everybody, and I think this is why you're seeing these models, it behooves us to bring the cost of health care down. And Congress had said, yes, we want to do that, but we also as a country can improve the quality of care, which is why most of us can't smoke in any buildings, right? And hopefully it means that some of us, and I heard a conversation between these two young ladies while we were waiting to start, and she said, my mother did smoke, and she did this and this, and yeah, she got cancer, and I've never smoked. So we're improving our own care. Thank you. Now if you have questions. His question is, on January 1, 2014, when pre-existing conditions will be covered, are there any ways to control the premiums? At this point, I've heard no, there is not. So, but it will be something between the federal government and insurance companies negotiating on what, because the Act does say you've got to provide good coverage. Because there's people out there who are paying, but paying very high and then still paying high deductibles. But again, that's not for Medicare beneficiaries. Her question is, what happens to the people who are 50 to 64 and they buy their own insurance? Will they be eligible for Medicare? At this point, again, Medicare stays there, and that's where we're all working towards. So yes, the concept is that we would keep Medicare, and it will still be. Now there is a proposal to raise the age for Medicare eligibility, just like they've raised it for Social Security. But again, those are still proposals. It would take some implementation time beyond passing Congress. Okay, very important. Her question is, when the Affordable Care Act comes about, should you drop your Medicare Supplement policy? Medicare Supplement is a type of policy that is meant to work with original Medicare. Some employers offer their retirees a Medicare Supplement, and it's a specific plan. The Affordable Care Act, again, for those people not yet on Medicare, does not change Medicare. Right now, the only proposal, and again, it's a proposal, and the only part that was in the Affordable Care Act is a provision that said, if people have Medicare and a Medicare Supplement policy, nobody's controlling them going to see the doctor. So maybe if we make the beneficiary who has that Medicare supplement pay more, so pay deductibles, pay more out of pocket on their own before the Medicare supplement plan, the group that worked within the Affordable Care Act rules came back and recommended unanimously, don't do anything to Medicare supplement. You do not want to drop that policy without really understanding what's left out there, because you dropping a supplement is not like these Medicare Advantage plans that every year change. You drop that policy, you may not be able to get it back. Her question is, if the cuts are made to providers, won't they pass that on to the patients? Not to you as Medicare beneficiaries. And the reason is Medicare is a national program. Medicare knows what the cost of care is because they pay premiums. So in an area, once Medicare has approved a service, they dictate what they will pay for that service. So, and they're going to pay what they've dictated. And if you have a supplement, if you're an original Medicare, you'll hear that you pay 20%. What we are seeing at Medicare Advantage plans, again, those are those plans that said we can do it cheaper. When they started, many of them gave away many things. The cost has gone up. Now, some of those Medicare Advantage plans have co-payments, co-insurance, and they look just like the same amounts as. So again, that is why Medicare is saying, you plan said you could do it cheaper. If you're not able to do it cheaper, we're going to cut you. You get to decide whether you're going to play or not. So we're going to see fewer plans, but in Medicare, they cannot automatically pass it on to you as a Medicare beneficiary.
Okay, so that's illegal to do that.
Correct. And I will tell you, in Austin, I have seen people who are in original Medicare. If you read that Medicare summary notice carefully, it will say, your doctor billed this, we approved this, we paid this, you are not responsible for this. And I have seen patients who've said, yeah, but when I went to talk to my doctor, they said that Medicare doesn't pay them enough. And I said, you have a right to report that. That is abuse, because they've agreed to work with Medicare. There are, where it does impact you is, some practices have said, we will no longer accept Medicare. Then again, some of them back off and say, we will keep the Medicare patients that we have. We're not going to accept new Medicare beneficiaries. Don't tie yourself to 2014. If you're having problems finding doctors who will work with, that accept Medicare, you can begin by calling 1-800-MEDICARE or going online to Medicare's website, and it will tell you which doctors accept Medicare. I've heard this on and off. Look for help. And like I said, 1-800-MEDICARE keeps a list of doctors who have said they will work with Medicare. You may have to do some phone calling. While we're in all of this transition, insurance companies are trying to keep their profits. Doctors are trying to meet their costs. So you're going to see some turmoil. But, you know, I'm not going to say it's going to, I don't have that magic, you know, ball. Her question is, when her doctor orders a test and Medicare denies it, are you in original Medicare? Okay. And do you, so in original Medicare, you go get the test, and because there's no prior authorization or approval in original Medicare, So you go get the test. It will come back, your Medicare summary notice will say it was not medically necessary. And again, Medicare is using national standards saying, why did you give them this test? Again, if you look at the Medicare notice, it will say you do not have to pay this or you do have to pay this. Be careful of signing in the Medicare and You book a release form at the lab that says you're agreeing to pay if Medicare does not cover this. That is an alert to you as a beneficiary. Well, why is my doctor ordering something that Medicare won't cover? Half of the time, it is because that doctor's office or whoever billed coded it incorrectly. And what I tell patients to do is call up your doctor and say, why did you order a test that Medicare won't cover? Writing review on that Medicare summary notice begins your right to appeal why payment is being denied. Don't automatically pay it. And be careful of signing those notices. Okay, I can't hear all of you talking.
If you sign an ABN, an advisement,
then
you will be billed.
Yes, if you sign an advanced beneficiary notice, which is what I just said, be careful of signing that, because you signed that before you got the test. Now, if you think you signed that notice 5 months ago when you started seeing that doctor, that notice is only supposed to be issued, and therefore that should be an alert to a beneficiary. Why are you ordering a test that Medicare won't cover? Okay?
If you don't sign it, will they still have to give you the test?
Her question is, if they don't sign it, will they still give you the test?
Yes.
The lab may or may not, so you go back to your doctor and say, okay, why are you doing a test that is counter to Medicare? Because Medicare is based on medical statistics that show that for this condition, you do this test.